G'day, I'm Gary Burke. I'm a GP from Bendigo Community Health, and I would like to welcome the presenters of from the Victorian Clinical Genetics Service. So Gemma Brett and Dr. Alison Archibald are genetic counsellors. Amanda Detman will speak with us later. Amanda's a business development manager and will tell us a little bit about collection sites, among other things. And Professor Ravi is the clinical geneticist. I did want to recognise that this event started or had its genesis because of an interest of some GP registrars at our clinic at Bendigo Community Health and through conversations with VCGS, Bendigo Health and eventually Murray PHN, we've got this webinar on the way. Next slide. I'd like to acknowledge the traditional owners of the lands on which we meet today. We pay our respect to the elders past, present and emerging, and extend that respect to all Aboriginal and Torres Strait Islander people. And I just wanted to point out that the antenatal, within the antenatal screening or the pregnancy planning, or in fact any page on Murray PHN, there's an opportunity to send feedback. So there's a send feedback up the top right and down the bottom left. I just thought I'd show you some Murray localised pathways. So just be aware that if you ever want to see the specific pathways that have already been localised for Murray PHN, they're here. So there's a whole variety of them. And within localised pathways, of course, you can get referral pathways to some of the specific specialists and allied health providers within your region of Murray PHN, whether that be central Victoria or some other regions. The other thing that I wanted to show very briefly before I allow or get the staff from VCGS to present is just a couple of extra links from, and I'm not going to spend a lot of time on this, just to let you know that they exist. So RACGP has produced a program called Beware the Rare. It is a focus on reproductive carrier screening and on spinal muscular atrophy. It's just a matter of typing in Beware the Rare and the RACGP program will come up. That's one of the ones that I wanted to make you aware of. The second one is that the RACGP has a more comprehensive genetic resource there, just called the RACGP Guidelines on Genomics. So Genomics in General Practice is what it's called. Again, you can get in there and download it. The Red Book, as you know, and I'm not going to go in there, but it does have a chapter on genetics. VCGS are the presenters tonight. We've looked at the genetics at Murray PHN. There is some information that's going to be presented to us about Mackenzie's mission. It is a government-funded pilot study, but it's not available in all areas of all states. And then finally, this is, even though it's not Victorian, I think this is a really useful website. It's from New South Wales. It's called the Centre of Genetics Education. There's information for general practitioners, including a whole bunch of tools. So I just wanted to start by introducing Gemma Brett, the genetic counsellor who I've had most to do with, and Gemma will later on hand over to the other speakers.
Great, thanks Gary, and thanks for inviting us to have a bit of a chat tonight about genetics in primary care. As Gary mentioned, myself and Ali Archibald are genetic counsellors. I'll talk a little bit first about VCGS and what we do in your region, a little bit about the hemoglobinopathy. So thalassemia is one of the topics that I understand everyone was a little bit keen to hear more about. And then Amanda will speak after Alison covers all of the other areas of reproductive carrier screening and some pregnancy testing information. Amanda will speak about the carrier sites that the collection sites that we have, and Ravi will join us to answer your questions. So it's not letting me change slide. Perhaps to the next slide, please, if I'm not able to have the control. Thanks. Thanks. So BCGS is based out of located at the Royal Children's Hospital in Melbourne. We're a not-for-profit, and we were the first clinical genetic service in Victoria, and we did cover all of the hospitals throughout the state. And as each hospital developed their own internal, the tertiary level hospitals in Melbourne developed their own genetics department, we still cover the Children's Hospital, and we cover the regional areas. Next slide, please. So we provide clinical services and laboratory services. In addition to the Children's Hospital in regional Victoria, we do also cover Northern Territory. And as you'll hear a bit more about tonight, we provide genetic counselling services regarding reproductive carrier screening and prenatal testing. Tonight we'll talk mostly about the laboratory services, which are the carrier screening and NIPT. And perhaps at another time, if there's interest, we could talk more about the paediatric testing we offer in chromosomal microarray, Fragile X syndrome, and then some other more complex areas of genomic sequencing. And that's more about the specialist genetic testing that we offer these days. Next slide, please. Our clinics in the regional areas of Victoria, as you can see there's a few across the Murray region. We've got Bendigo, Mildura, Shepparton and Wodonga. All of our clinics are publicly funded, so the families don't have out-of-pocket consultation costs. We do see families from across the border from New South Wales and South Australia, again, at no cost to them. We have a state-based agreement for that. Unfortunately, many genetic tests do have out-of-pocket costs, so sometimes we are lucky to be able to obtain funding for those, but sometimes we have to have conversations with families about whether they're able to part or fully fund out-of-pocket costs if they want to proceed with testing. And just an important point there that we, in the regional areas, we cover adult and paediatric general genetics in terms of the visiting clinics. We don't cover prenatal because we only come a few times a year, and of course, pregnancies don't wait for that. And we also don't cover familial cancer. There's other tertiary level genetic services in Melbourne, out of Royal Melbourne and the Austin hospitals that cover the different regional areas of Victoria for cancer genetics. Next, please. So this is a little bit of an overview of what we're touching on tonight. In terms of the preconception, we'll be touching upon the hemoglobinopathies, and the carrier screening included prepare and expanded carrier screening. And also we'll talk a little bit about the non-invasive prenatal screening. Thanks. So you might be familiar with the concept of genetic carrier screening, that it provides families or people considering having children a little bit more information about what might come in those children in terms of their health. Of course, it's ideally performed pre-pregnancy. We can do it in early pregnancy, but obviously that does cut our timelines a little bit tight in terms of providing families with the information they want in terms of thinking about reproductive choices. And it's important to remember that most carriers have no family history. And as you can see over on the right there, that we're talking about not only autosomal recessive conditions, where it comes from both parents, often hidden through the generations, but also talking about what are called X-linked conditions that come through on the X chromosome, often from a carrier mother, because of course you've got that scenario where men only having one X and then the Y chromosome, often men are more strongly affected by X-linked conditions, although it does depend on the condition. Thank you. So I'll just quickly touch a little bit on the hemoglobinopathies. I'm sure you're all familiar with the role of hemoglobin in the body, but just to flag here that, of course, genes determine the structure of each globin chain, and the globin chains forming together, you know, it's important that they're all there in doing their jobs in order to carry the iron molecules through the body. And there's different ways that we can have that not functioning to the full extent. Next, please. The hemoglobinopathies generally fall into two main categories. So we're talking about those gene variants that affect the quality and structure of hemoglobin versus those that affect the quantity of hemoglobin. So the latter, the thalassemias, are the ones that are sort of heard more commonly, particularly in your region, and I'll explain a bit more about that later. But certainly there's lots of different things that can go on here. It's just that some of these conditions are quite a bit more rare than others. Next, please. So this is what I wanted to show in terms of why it is that we do see in the Murray region a sort of higher carrier incidence than perhaps in some areas of Australia. It's a lot to do with the ethnic migration to the different farming regions of the Murray, and particularly you can see there in terms of beta thalassemia. That's something that you might be familiar with, knowing that there's communities within your area that have a higher prevalence of beta thalassemia carriers based on their ethnic populations that have moved into the area. Next, please. So these hemoglobinopathies, they're the autosomal recessive inheritance that I mentioned earlier, and of course that means they affect both genders equally. So for a carrier couple, that's a 1 in 4 or a 25% recurrence risk for most of these conditions. Thanks. So beta thalassemia, like I mentioned, is one that you might have come across having carriers as your patients as primary carers in the Murray region. And people might mention that they have beta thalassemia trait. That's often a common term for being a carrier. So that's like here in the top row where you can see some of the parents there are shaded in. So if we're looking at the diagram on the left, that's showing a couple where one of the parents, it doesn't matter which gender we're talking about here, although they have drawn that in, one of the biological parents there is a carrier of beta thalassemia and the other's not. So you can see that their children are either going to be carriers or not, and not have any medical concerns themselves. Although it still is important that that family can be aware of the fact they have carriers, because down the line, if you end up with the scenario on the right, where you have 2 carriers together, that's where you get the 1 in 4 chance of having a child with beta thalassemia major, which of course is a severe form of beta thalassemia and actually can cause health complications in terms of needing blood transfusions, and then an iron buildup in relation to that, and many health needs. So families being aware if they are carriers and having this 1 in 4 risk can help them be informed about that condition and decide whether they want to make choices about having reproductive testing, or whether they are now aware and happy to go forth and have children, and just let us know once they've had children, so that we can care for those that might need extra medical help. So then if we go to the next slide, that's about alpha thalassemia. And this one gets a little bit more complicated, because actually we all have, rather than just simply, 2 copies of the beta thalassemia gene, which is a nice, easy way to show the inheritance. You can see here for each of the parents, we're showing that actually you've got, on both sides, you've got 2 copies of the alpha thalassemia gene here and here for each of them. So the reason that this one can be a little bit confusing to deal with in clinical practice is because you can see there for the couple on the left, you've got a couple where we're saying, okay, they're both carriers, and depending on whether they're passing on 1 copy of the chromosome or the other, they're either passing on a copy that does have the genes or the one that doesn't. So that's like the inheritance scenario we talked about earlier, simple recessive, autosomal recessive inheritance, and you've got a 1 in 4 chance there of the child having hydrops fetalis, or HB Barts as they call it. And so those children don't survive very long after birth. And again, having families who are informed about the possibility of this, if they are in this carrier scenario, can help them through what could otherwise be quite a significantly more difficult period for them if this comes as a surprise. But you can see the more complex things that can come with being a carrier of alpha thalassemia here is over on the right-hand side, that actually you can have this scenario where someone's kind of like being a hidden carrier of it, because it looks like the man that's drawn in actually on both copies of the chromosome, he's got some functioning copies of the alpha thalassemia gene, but you can see there that you can still end up with a child who has a different type of severe health condition that again can require some blood transfusions and ongoing health care. This actually comes out of the New South Wales Genetics Education Department, which Gary mentioned their website earlier as a great resource. It truly is, and one that we use ourselves to get handouts for families. So if you do, even if you just Google New South Wales Health thalassemia or Genetics Education New South Wales thalassemia, you'll find a great PDF document. Actually, I can share that around via Murray PHN afterwards when they put together the resources for this talk. There's a great document there that clearly explains, has these pictures and has some explanations about the risks, and it's a form that can be, in a form that can be provided to families. Next, please. So not to make this more complicated than it needs to be, this is not something that I think in primary care you need to memorize or that you need to have or anything to that effect. Essentially, in the next slides after this, I'm going to give you the true sort of take-home messages. But I just wanted to flag here that it does get more complicated in terms of which type of hemoglobinopathy carrier are you and who is your partner and what are they a carrier of, and there's different combinations that can have more or less serious health risks out of it. And as you can see there, we are more than happy to see families who are in one of those categories where there is a risk to the next generation. So if we just move on to the next, you can see that the Monash Pathology Thalassemia Laboratory, they also give these guidelines about, this is out of the RACGP in terms of looking at the different levels in the blood and things. And again, sometimes clinicians call us and say, oh, look, I'm reading all of these different things. I feel like I'm reading tea leaves. What am I seeing? Do I need to refer them or not? It's great that this lab has said, we're just one phone call away and we take care of what specific testing is needed. And I think that's the important thing to remember, that as I'll show you in the next slides, there's actually a simple pathway that you can remember. Thanks. If you look here, that actually just thinking, all right, are they in one of these high risk groups? Do they have family history? Are they of an ethnic origin that has a higher incidence of thalassemia carriers? Or actually, do they have one of these abnormal FBE results? Simple from there, take bloods from both of the couple, both of the intended biological parents, and I'll show you on the next slide how to do that. But if we just look here first, you can see that if from that laboratory it comes back and says potential risk for carriers, they're either both carriers or it's a bit unclear because they're carriers of two different types of thalassemia or other hemoglobinopathy, refer them for genetic counselling. If they're pregnant, refer them urgently, obviously not to our regional clinic, but to one of the women's hospital or other prenatal services in Melbourne. And if they're low risk, then essentially it's just about you guys communicating back to them that you're carriers as a couple. The laboratory has said you're not carriers of two of the same thing or any of the things that can have a risk for your next generation, but it is important to communicate to your patients that they should discuss with their families the potential for other people in the family to be carriers as well, because then they will be armed with the knowledge that those future generations or blood relatives in the adult generations can have carrier testing themselves as couples to try and work out if they do have a risk. And in terms of thinking about, how do I know if they're in this potential risk category or not? Well, that's the great thing about that publicly funded Monash Thalassemia Laboratory. So they actually are block funded, state government funded, to do thalassemia testing for all of the residents of Victoria. We do sometimes struggle a little bit with our families that have come across the border to one of our regional clinics. But this laboratory here, Monash Pathology Thalassemia Laboratory, they, in their reports, as long as you've sent them both couples samples so they can do the full analysis themselves, they do all the thinking and they will write back to you in the laboratory report whether these couples are at high risk or not. So if we just jump forward past the flow chart, the last slide of what I wanted to show you today is actually an order form. How do I, from a practical level for you, how do I do this? What do I do? It doesn't have to be on this exact pathology form. It can be on the pathology form of your choice, but these are the important things. It's very important that you test both partners together, because only that way can the Monash Pathology Thalassemia Laboratory do that work to logically think, this couple together, are we talking about a high risk scenario or not? For both of the partners, we're looking to do the FBE, the iron studies, and also the HB electrophoresis. And it's very important that you write that fourth thing, plus or minus DNA studies if required. And now the reason we need you to write all of these things on the same pathology form in order to truly be able to say back to the couple that you're seeing whether or not they are high risk is because no matter which of your local pathology services that does the blood collection from this, if you've written these four things on, the onus is on that pathology company to on-send to the Monash Thalassemia Laboratory for them to do those last steps, because they're the only ones that do it. And they're the experts, and they're the ones that'll, even for us, that we call and say, what does this result mean? I just need you to talk me through it. And they have lovely scientists that help us nut out the ones that do get a little bit complex. Of course, I flagged there that we're talking about EDTA blood samples, so that we can make sure that there is viable DNA when it gets down to that lab. And I can't stress enough, and the laboratory has stressed to me, you must tell all of the clinicians, please, please, please write the partner's name, date of birth, address, and Medicare number, because without that, you'll find that you get two separate reports back from the laboratory for two people that they've treated as individuals and haven't made a overall finding in terms of the couple's risk. So I'm more than happy to take questions about this at the end, but for now, what we'll do is we'll move on for Alison to have a bit more of a chat about some other types of carrier testing and then onto the pregnancy testing. Thanks.
Thanks, Gemma. I always find hearing about that really helpful because hemoglobinopathies are really complicated and it's always good to have a bit of a refresher. So I'm going to continue this sort of theme around carrier screening and talk about carrier screening a little bit more generally. And then I'm going to go on and talk about NIPT as well. So I guess one of the really important messages around carrier screening is that this is something that is now recommended to be offered to any couple planning a pregnancy or early in pregnancy. And we've really seen a shift in guidelines over the past years around this. So back in 2015, the statement was carrier screening may be offered, whereas mid-2018, we're now looking at saying it should be offered. So it really is something to really think very carefully about incorporating into your routine practice, actually incorporating the offer of carrier screening. I'm just going to see if I can move the slides. No, I can't. Okay. So when we're talking about carrier screening, the conditions that are recommended to be screened for at the moment are cystic fibrosis, Fragile X syndrome, and spinal muscular atrophy. Now, the recommendations do also acknowledge that there are also panels which screen for a much larger number of conditions, into the hundreds, and those are also an option to offer to your patients. Obviously, those come at an increased cost as well. One thing that's really interesting and a very, very new development, and we can talk about this a little bit more at the end, but is likely, if it comes in, to have quite a significant impact on your practice, is that the Medical Services Advisory Committee has recently recommended carrier screening for these three conditions have public funding, so through a Medicare item number. So it's possible that as early as mid next year, there may actually be a Medicare item number for any family, any couple considering a pregnancy or early in pregnancy to have access to funded carrier screening for these conditions. So it's certainly something that's important to have on the radar. So why these conditions and what is it about them? So they're all very common inherited conditions. Cystic fibrosis and spinal muscular atrophy are autosomal recessive conditions, and Fragile X syndrome is an X-linked condition. They're all conditions that have quite a significant effect on lifespan and quality of life, depending on each condition's a bit different, but they do have quite a significant impact. We've also done a lot of research around this area, and the research has shown that health professionals, couples who have children with these conditions, and the general community actually really support the idea of offering carrier screening for this, but always provided it's optional. So there's actually been a lot of work done around this topic in Victoria, so it's really nice to have that research really informing directions in practice. Next slide, please. So some of the other reasons why carrier screening is being recommended for these conditions include that we know through our work on Prepare, which is our carrier screen for these 3 conditions that BCGS offers, that 1 in every 20 people is a carrier for at least one of these conditions. And there are situations where people can actually be carriers for more than one condition. So we've found a few people in that situation too. So in addition to these conditions being common and severe, there are also very good tests available for them that really have good sensitivity and specificity. Next slide, please. So as I said, what we've actually found with Prepare has really supported what we already know about carrier screening, and that is that most people who are carriers have no family history. So if you rewind 5 to 10 years, a lot of people sort of thought, you know, you really should only offer carrier screening when there is a family history of the condition. But if there's one key take home from my talk tonight, it is this is something that is relevant to every couple who is considering pregnancy, because these conditions can be passed down through many generations in a family without anybody being affected. And for the autosomal recessive conditions, it may be that it's just the chance that 2 people who decide to have a child together actually happen to both be carriers for that same condition. So we've done a lot of screening with Prepare. We published some our experience of the first 12,000 couples screened through this program. And interestingly, we found that about 1 in every 240 couples have a high chance of having a child with one of the 3 conditions. And the affected pregnancy rate was 1 in 1,000. So that's actually equivalent to the live birth rate for Down syndrome in a woman of approximately 30 years. We also found that women and couples who do have an increased risk of having a child with one of these conditions do use the information in their reproductive planning. Some choose to access pre-implantation genetic testing with IVF, and others choose prenatal diagnosis, with some choosing to have a termination of pregnancy if the pregnancy is affected. So it is information that people do value to incorporate in their decision making. So how does the screening actually work? Well, for these, when you're screening just for these 3 conditions, this is the way that we suggest you offer it. So we suggest screening the female partner first, okay? And if she receives a low risk result for all 3 conditions, then no further action is required. So it's pretty simple. If she gets a carrier result, then genetic counselling is offered. So if you do your carrier screening through the Prepare program, you'll actually get a call from me or one of my colleagues. We're all genetic counsellors, and we will explain the result to you and offer to provide genetic counselling for your patient. So if the female partner is a carrier for CF or SMA, then we will recommend offering carrier screening to the male partner. If it's a couple conceiving using a donor, then obviously it's the biological parents that need to be tested, so the donor would need to be tested. If the male partner or donor is low risk, then no further action is required, because together the couple have a low reproductive risk of having a child with that condition. If the partner is a carrier for CF or SMA, then that couple have a 1 in 4 chance for each pregnancy they have that pregnancy would be affected. They have the option of prenatal diagnosis if they would like, or if they're not pregnant at the time of testing, IVF with pre-implantation genetic testing. In the situation where we have a female who is a Fragile X carrier, then she has up to a 1 in 2 chance of having an affected child for each pregnancy. It's really important to emphasise that even though Fragile X syndrome is an X-linked condition, females and males can both develop Fragile X syndrome. So females can be affected too. So a common misconception about Fragile X carrier screening, often we hear, that's okay, she's had NIPT, she's having a female, we don't have to worry about it. That's not the case. Fragile X can be more variable in females, but some females can certainly be as severely affected as males. So it's important that patients are made aware of that. For any carrier couples or Fragile X carriers, we also offer specialist appointments as well. So for example, for CF carriers, we have a respiratory physician who's very happy to see those couples, help them understand what cystic fibrosis is, what the day-to-day impacts are, so that can help inform their decision making. The other important element to just mention as well is that carrier testing for blood relatives is really important too. Next slide. Okay, so I've mentioned prepare carrier screening, which is for the 3 conditions, but as I also mentioned earlier when I was talking about the guidelines, there are actually larger panels as well. So couples wanting a more comprehensive carrier screen can opt to have screening for hundreds of different genetic conditions. At the moment, we send that away to the US. We're working on our own in-house version at the moment. It's just not currently available, so we send it away. It screens for just under 300 conditions. If you're doing the expanded, we really recommend you screen both partners at the same time. And that's just because the larger the number of conditions you screen for, the greater the chance that someone's going to come back as a carrier. So for this carrier screening that we do, about 70% of people screened actually come back as a carrier for at least one thing. So it makes sense to just screen the couple at the same time. The results come back together. Our laboratory actually has a look over those results, reviews them, and issues a combined couple result, which is really useful because then you can say, right, is this couple low risk or are they increased risk? For couples who do have an increased risk, again, you get a phone call from the genetic counsellor. We give you all the information you would need to kind of convey that to the patients, and then we offer genetic counselling consultation, and we can do them by telehealth. The cost for this works out to be about $895 per couple, whereas the prepare carrier screen at the moment is $385, and hopefully will be very affordable if a Medicare item number does become available. Next slide. So the other thing that you might have heard a little bit about is a research project called Mackenzie's Mission. I'm doing a lot of work on this at the moment. This is a 3-year government-funded research project. It's looking at how best to offer reproductive genetic carrier screening as a national program. It's called Mackenzie's Mission because it's named after little bub here, Mackenzie Casella. So her parents, Rachel and Johnny, did everything that they thought they needed to do before having a family. They went to their GP, they asked what tests they needed to have. They tried to tick everything off the list they possibly could. They weren't offered carrier screening. They went on to have Mackenzie, who had spinal muscular atrophy and passed away at 7 months of age. So they have really strongly advocated for carrier screening, along with a range of other people in terms of health professionals and patient support organisations. And that really was the catalyst for this government research project around carrier screening. So we're offering Mackenzie's Mission through selected healthcare providers across the country. 10,000 couples will be screened at no charge, and we're screening for 1,300 genes, which cover about 750 severe childhood onset conditions. We're actually looking for clinics in your area that are interested in taking part. We can't have a large number of clinics, but if anyone's interested, it would be, I'd definitely be keen to hear from you. So moving on to non-invasive prenatal testing. So at VCGS, the NIPT we offer is our homegrown NIPT called Percept, which I'm sure you've heard about. We've offered NIPT since 2013 and on site at VCGS since 2015. We consider this an advanced screening test because we're assessing pregnancies for whole chromosome aneuploidies and also segmental aneuploidies. I'll tell you a bit about that in a minute. We see a significant improvement in sensitivity and specificity compared to traditional combined first trimester screening. This is also highly accurate for fetal sex as well.
So NIPT is a process through which we sample the fetal DNA, the DNA from the growing fetus, from the maternal DNA, well, from the maternal blood sample, I should say. So if we take a sample from the woman, from the arm, floating around in that, there's little fragments of DNA, and the majority of those fragments of DNA will, of course, have been shed from the woman's cells themselves. So as you can see there, it's about a 90% rate compared to a 10% of that free DNA floating around that's actually come shed from the baby and transferred by the placenta into the woman's bloodstream. So that's what we mean when we say that the cell-free DNA, and we'll talk a little bit later about this importance of the ratio, how much fetal DNA is there flowing around at that time.
So basically, what's really important to understand with NIPT is that we're looking at placental DNA, okay? And most of the time, that is what we're seeing in the fetus as well. But some of the limitations of NIPT are actually around the fact that we're looking at placental DNA. So
sorry, Ali, sorry to interrupt, not your night. Just hold your microphone out a little bit, please. Thank you.
Okay. So just you can see highlighted here that as the cells divide in the developing embryo, actually what ends up being the embryo is actually quite far removed from what ends up being in the placenta, and it's the placental DNA that we're looking at NIPT. Okay, next slide. Okay, so some of the things that are really important to understand around NIPT are a term that you probably will have already heard, which is referred to as fetal fraction. So that's the proportion of fetal DNA that is within the maternal blood. And the fetal fraction ranges from about 1 to 25%. We know that it increases with gestation, and it also decreases with maternal BMI. So maternal BMI is an important factor to be aware of when we're actually doing the NIPT. We also know that some medications and medical conditions can decrease fetal fraction as well. So sometimes when we have to issue a failed NIPT result, which doesn't happen very often, sometimes it's because of the medication that the patient is on. It's also important to be aware that different NIPT providers have different cell-free DNA fetal fraction cutoffs, and this can lead to different failure rates. So with Percept, we actually have a limit of detection at 2.5% fetal fraction, which equates to a failure rate of 0.2%, which is actually very low. Next slide. Okay, so as I mentioned before, what we're offering with Percept is a whole genome NIPT, whereas some other providers are only looking at the chromosomes associated with the more common chromosome conditions that we see, so trisomy 13, 18, 21, X and Y. Next slide. So this is just some more scientific data, but sort of it gives you an indication of what we're looking at with NIPT. So with the whole chromosomes, we're looking for whole chromosome aneuploidies. So in this line graph, you can see a blue line and a big peak. So that is actually telling us that there's a whole additional copy of chromosome 4. And in the image next to it, you can see that where there's chromosome 4, there's a big pink band, and that's a different way of looking at the data, but also showing us that there's a whole additional copy of chromosome 4. The other thing that we do with our analysis is we actually break the chromosome data up into sections and look at it to see whether there's any change in amount of signal across the chromosomes. So here you can see for chromosome 3, we're seeing a normal signal most of the way across, but then we see this this big pink band and this elevated red line. That indicates that we're seeing extra signal from chromosome 3 in that region. So potentially suggesting a duplication of that area of chromosome 3. Next slide. So how does it work, and when do you offer it, and when should you not offer it? So NIPT is available from 10 weeks gestation. It's mostly used as first-tier screening. So you can use it in the sort of contingent model where you have combined first trimester screening first, and if it's increased risk, then you can offer NIPT in certain circumstances, and I'll come back to that in a minute. Or increasingly what we're seeing is patients are just going to NIPT as a first-tier test. It's preferable to have a dating ultrasound before having NIPT, and that's really because NIPT is quite an expensive test. It's $449. So you want to confirm that the pregnancy is ongoing before you're offering NIPT. It also clarifies whether we're looking at a singleton or a multiple pregnancy. We can do NIPT for twins. For higher order pregnancies, we really need you to contact our lab so they can assess whether or not they can do the NIPT, but we've certainly done it for some triplet pregnancies before. It also allows us to clarify the estimated date of delivery And that just avoids a situation where someone actually has the NIPT too early, because we know that patients are always really keen to have the NIPT right on 10 weeks. So they're always disappointed if they actually end up having it too early. So when is it suitable? It's suitable, as I said, for singleton and twin pregnancies, women of age, any age or ethnicity, couples using who've gone through IVF or are using donors for their pregnancies, women who have a high risk for aneuploidies due to advanced maternal age, increased risk on maternal serum screening, or personal or family history of aneuploidy. It's really not suitable when there's an ultrasound abnormality identified. And that's really because sometimes those can indicate a different genetic condition that might not be picked up through NIPT. Also, if there's an increased nuchal translucency, again, it's much better to go straight to a diagnostic test, and NIPT is probably just a bit of an expensive detour there. Also, we wouldn't suggest NIPT for combined results over 1 in 50 because, again, while they often may indicate Down syndrome, there are actually other chromosomal conditions that might be there, and they might be missed with NIPT. So again, we'd suggest just go straight to a diagnostic test. Our genetic counselling team is available to speak to people about decisions around whether NIPT is appropriate, and sometimes we will contact the referring doctor if we want to clarify anything on the test request form before we perform the NIPT. Next slide. Okay, so how do we order it? So we've got a specific test request form, and the reason for that really is that there's some quite key information that we need to provide. So you just discuss NIPT with your patient, give them the brochure that comes alongside the test request form. If you feel like the patient would benefit from some pre-test genetic counselling, we can certainly offer that to them. You complete the request form and as best you can, actually complete all the sections, because as I said, that information is really important to us. It's important to have blood collection after 10 weeks. It's really great if it's done around 11 weeks. That's usually a good time to do it. We've got specific collection sites, and there's a link to some collection sites in your region that's been posted up there. Turnaround time is 3 to 5 working days from when we receive the sample, so it's pretty quick to get a result. And we communicate the results directly to the referring health professional. You'll get a call from our genetic counselling team, and we can provide telehealth consults if patients want to discuss their results in more detail. Next slide. So this is just an overview of the detection rates for NIPT. You'll see that most of them have high sensitivity and specificity. Some with the positive predictive value are a little bit on the lower side, and I'll go into that in a bit more detail in a minute as to why. But overall, it is a very comprehensive and advanced screen. Next slide. Okay, so one of the things that people often ask about is, in addition to chromosomes 13, 18, 21X and Y, why do we bother screening the other chromosomes? And there are quite a few reasons for that. So one, what we call rare autosomal aneuploidies occur relatively frequently, so about 1 in every 300 NIPTs. While the non-mosaic forms of these can be lethal and usually result in miscarriage, there are a number of considerations to be aware of. So it's important that these are interpreted in conjunction with ultrasound. So often if you do get a high risk result for a patient for a rare aneuploidy, the first thing we'll say is, have they had a scan recently? And we'll suggest a scan so we can see if there are any markers on that ultrasound, or if the pregnancy is actually miscarried. So the first one is, it often is an explanation for miscarriage. It's also important to be aware that we do sometimes see what we call true fetal mosaicism. So where there are some trisomic cell lines in the fetus, but not full trisomy for that chromosome, and so that's why the pregnancy is continuing. So in that situation, it's important that the patient is able to access prenatal diagnosis. Sometimes we find that there's confined placental mosaicism, and that can really mean that the trisomy is in the placenta, but not in the fetus. We can also sometimes see uniparental disomy. We also sometimes find that with these rare trisomies that if it's only in the placenta, it can sometimes affect it can be associated with intrauterine fetal demise or intrauterine growth restriction. So actually, it may mean that the pregnancy needs to be monitored a bit more closely. Also, we can see normal pregnancy outcomes in this situation, but there are a lot of reasons why it actually does add some value to include the other chromosomes in the analysis. Next slide. So this is just an example of some data here, but it also highlights the importance of looking for segmental changes. So while we're looking across all the chromosomes, as I mentioned before, we can pick up where there are sections of additional or missing genetic information. And these are just some of the syndromes that we're able to pick up. And just move to the next slide. So you can also see here that all the little orange bits across all the chromosomes just highlight different segmental aneuploidies that we've picked up. So sections of chromosome material that's deleted or duplicated that can actually be associated with a particular type of syndrome. So that's another benefit of doing the whole chromosome analysis. Next slide. Okay, so this is just moving on to, this is just what a high risk result looks like for Percept NIPT. So this is a high risk result for trisomy 21. And if you move on to the next slide. So this is how we manage the high risk results. So when a high risk result is issued, you'll get a call from our genetic counselling team. And you'll have to click through these, and I'll just try and time my talking as best as possible. So it's one of the things that's really important for us to know is, has there been a co-twin demise early in the pregnancy? Because sometimes that can actually be the reason for the high risk result, that actually it might have been in a co-twin. Very occasionally we see that mum's walking around with some extra or missing genetic material and is completely fine, but that has been what's caused the high risk result. And if we think that that's the case, we'll suggest maternal chromosome analysis. But usually the first step really, as I mentioned, is, are there any findings on ultrasound? And if there are, then we would recommend a CVS, basically just because it can be done earlier, so the the patient gets the information earlier. If not, then ideally we would recommend an amniocentesis. And that's just because with an amnio, you're looking at cells in the amniotic fluid that have come directly from the fetus, whereas a CVS, you're actually sampling the placenta. Okay, I'll just let this flick through. The other thing, it's going to pop up in a minute, but the other thing that we also do is in situations that do look like a false positive result, we actually sometimes ask if we can have a sample of the placenta at delivery. And that's just so we can see whether or not it is actually in the placenta and it just wasn't in the fetus, and that's why it was a false positive result. And I'll come to that in a minute. I think it might be on the next slide. So I've mentioned false positive and also we get false negative results. Why do we get them? So there are a range of reasons why a high risk NIPT result might not actually be confirmed in the fetus. So a number of them are maternal. So we certainly see women who have sex chromosome aneuploidy, which may cause the result to be high risk in the pregnancy. We sometimes actually see malignancy in the mother, which can look like a high risk result in NIPT. If that's the case, we'll usually call you and have quite a detailed discussion about the clinical situation before we report anything. But the main reason is placental. So usually we're seeing additional cells in the placenta in terms of with the trisomy, but not in the fetus. What's really important to understand though is that when you do see a false positive result, it's almost always not because the test was wrong, but usually because there was a biological reason for it. Okay, that's okay, you can flick through. So this is just to highlight that you can have a genetic change occurring in the very early developing embryo, and that can pop up with trisomic cell lines in the placenta, but that's not necessarily in the fetus. Okay, next slide. So just a summary of Percept NIPT. It comes with expert interpretation. We provide detailed information about high-risk results, including whether we think there might be a mosaicism, rare autosomal aneuploidy. We report segmental changes. If you've got a patient who has as a carrier for reciprocal translocation, we can offer NIPT in that situation in some circumstances. We can identify whether there's been a co-twin demise. In some cases, we can offer the NIPT for triplets. And we certainly are doing lots of things to improve our positive predictive value. And we offer comprehensive genetic counselling. All right, I'll hand over to Amanda for this.
Thanks, Ali. So I'm briefly going to take you through how you might wish to access our tests, and we have already attached an attachment to the talk, which has a link to all of the testing sites that sit within the collection sites that sit within the Murray Primary Health Network. But to sum up, Prepare and Percept blood collections can be done through Goulburn Valley Health Pathologies, Austin Pathology, and Foresight Pathologies, who all collect for us. And we also have a few private practices that are willing to take external patients by appointment, of course, in Albury-Wodonga, Robin Vale, and Bendigo. It's worth noting that most private pathology companies do have their own versions of an NIPT and carrier screening, and so we need to ensure that if you're referring your patients, you do direct them through channels that will make it through to us. If you are interested yourselves in expanding your service offering and would be interested in collecting Prepare or Percept in-house, please reach out and contact us. We'd be happy to have that conversation with you also. And just in summary, Percept is it costs $449 and is a 3 to 5 working day turnaround. And Prepare is $389 with a 10-day working day turnaround. We test the female partner initially, and then the male partner, if required, is tested at no additional charge. Prepare, carrier screening can also be tested through saliva samples, and there are two options as to how you might access these. You can either provide your patients with a referral form and direct them to our online ordering site shown on the screen at the moment. We will then send out a saliva kit to your patient, and they can collect their sample at home and return it back to us via Australia Post. Or we can set yourselves up with saliva kits in-house, and you can issue your patient the referral form and the saliva kit while in consult. They can either do their test in the consult room with you, or once again, they can take their test home and do it at home and post it back to us. Expanded carrier screening, as we've already mentioned, is an offshore test for us at the moment. We do it as a combined couple test, and we also issue a combined couple report. It tests for 288 conditions and is at the moment a 3 to 4 week turnaround. We mentioned that it is approximately $895, and that approximation is just due to the fact that there's a component of that fee that has American money associated with it, so the conversion rate associated with that. For patients wishing to access our expanded carrier screening service, the site is there on the screen, carrierscreening@bcgs.org.au, and we can also provide you with some patient information as to how to access that service. If you would like us to provide you any further information about our antenatal tests or hard copy referral forms and how to access our saliva kits, you can also contact us at bcgs@bcgs.org.au, which I think is on the next page. Gemma mentioned briefly that we also offer paediatric genetic testing, and we can do this also via saliva kits, and the benefit of that is that it's very painless and quick, takes about 20 seconds to perform, can be done in the comfort of the patient's home, and we're getting results that are equal to or better than from blood samples, and once collected, the sample is stable for up to 2 months. So if you would require some information about that, once again, reach out to us at bcgs@bchs.org.au. And finally, just to highlight once again that all of our services are supported with our genetic counselling service, who will provide before and after test counselling as required for yourself and for your patients. So that's me done. Thank you.
So the question is, there's a lot of ethnicities to consider in testing for thalassemia, remembering that ethnicity was only just one reason for going further and doing the extra thalassemia testing. The other one that we come across quite often is the low MCH and low MCV that was recorded there. And the questioner has asked, surely if all these people with ethnic backgrounds were referred for testing, then that would overwhelm the system. Is there a way to effectively rule couples out of being at risk? So I suppose the question is, if a person falls in those ethnicities, do we still have to do it, those extra tests anyway? I want to add a little extra to that. I want to ask whether there's been any audits for those ethnicities for how often they are actually being tested for thalassemia testing, just to get an idea of, whether we might be missing some people.
Yeah, so I'll jump in there for a second, and then Ali might mention about these genes being on some of the expanded carrier screenings for people who want to go through these tests where you're paying for them privately. But in terms of the, that question of, would you not overwhelm the system if you ordered it for anyone who fell into these categories? I must admit I had a more detailed slide on this that I did remove from the talk because I was aware we were sort of getting to time limits. So thanks for doing a bit of a Dorothy Dix there for me. The Monash Pathology Laboratory team actually have a system through which, if you've written on the pathology request form that order of tests, I mean, it doesn't have to be in that order, but those tests that I had listed on the pathology form example, the great thing about that is they start with the more simple things, that laboratories are running all the time, the FBE, the iron studies, and actually through that, it's sort of, as it goes down the list, people are being crossed off in terms of, okay, they don't need to go any further because they don't have, for example, the MCV or MCH rates at the low rates that indicate further testing's needed. And in fact, the Monash Pathology team, they only progress to the alpha thalassemia testing if people have those low rates, are iron deficient, and if they have normal indices, they're only tested if their partner has the 2 gene deletion. There's a certain checklist that the laboratories go to in terms of making sure that they're not running the more complex and longer form tests for all of the people who are referred. They're actually crossing people off, saying we don't need to go any further for this one because we've made it clear that for this person they're not at risk of being a carrier of any of the hemoglobinopathies. That 1300 number there, we've got some great phone staff that triage your calls from there and send it through to perhaps Ali's team to talk about screening or NIPT, or you might end up being put through to the duty genetic counsellor, who could be me on any given day, or if you have other questions relating to sample collections and things, you might end up being put through to Amanda and her team. So really that's your one-stop number. Call that number, describe what you'd need, and you'll be put through to the right person. And if they can't help you on the spot, they'll certainly be having a chat with our other consultants like Ravi and getting back to you quickly.
Yeah, look, wanted to thank you, Gary, and wanted to thank Alison, Gemma and Amanda for doing a great job. So thanks for having us, and we'd love to come back again next year.
Thanks very much. And thanks, Gary, for facilitating. Good night, everybody.
Good night.
Thank you.